Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline, of course, is a 30-minute conversation where we like to focus on ways to help you live a healthier, happier, and pain-free life. We'll be taking your calls and answering any questions that you have live in the studio today. Those phone lines are not currently open just yet, but they will be in just a couple of minutes. And when you do call, make sure you're in a quiet room with your TV turned all the way down if you're tuning in on your TV so that we can hear your question. That number is 318-219-4569. It will be on the bottom of your screen in just a couple of minutes, so please give us a call. And today on Healthline, we're talking about abdominal pain. And here today to talk about this is Dr. Jay Howell with Willis-Knighton Surgical Associates. Thanks for joining us.
Thank you for having me. I'm happy to be back.
Absolutely, yes. And so first of all, tell us a little bit about what you do at Willis-Knighton, and you also have an important message to get out to our viewers today.
Yes, my friend Tracy, her mother had to have some unexpected surgery, and I just wanted to say, Miss Claudia, I wish you a speedy recovery, and please let me know if there's anything I could do to help you.
Absolutely, yes, and you do specialize in surgery, so I'm sure you're dealing with the nerves of people that are going. It's can sometimes be a scary thing to be put under the knife.
It can be. Oftentimes, I see all my patients the morning of surgery, make sure they're doing okay, see if they have any last-minute questions, and quite often they'll tell me how nervous they are. And I reassure them, and I say, if you're not nervous, I would think something was wrong. You're supposed to be a little bit nervous. I myself had to have surgery maybe 15 years ago, and even though it's something that I do every day and I'm very familiar with, was certainly nervous. So it's understandable.
Yeah, for sure. Okay, so how long have you been a surgeon practicing?
I started my internship and did my first operation in 1995.
Wow.
And finished all my surgery training in 2001.
Okay.
And have been in private practice, and recently over the last maybe 6 years as an employee for Willis-Knighton.
Nice, nice. So what drew you to pursue a practice or a career in surgery?
So part of your training in medical school, in the third and fourth year, you do several different rotations. You go through all the specialties, medicine, deliver some babies, do some surgery stuff, anesthesia, and you hope you find something that speaks to you. And it was an interesting situation. I had done all the rotations my third year and didn't really like any of them.
Oh no.
And thought, oh my goodness, is this the right decision? Did I make the right decision in this field? And the last rotation was surgery, and I liked it. I loved it.
Yeah.
And I like the idea that surgery is sort of finite. You have a very specific problem, hopefully a very specific problem,
right,
and you're able to identify, solve that problem, and then you can put that problem behind you. If I remove someone's appendix, I don't have to worry that they're going to be back next month with appendicitis again.
Right, yeah.
And I like the idea of being able to address and solve a problem.
Okay, and I'm sure that the difficulty of the surgeries, are probably a challenge. Every time you go in there, which now it's easier than maybe it was when you first started, but it's always maybe a challenge too. When you, like you said, a kind of a puzzle maybe.
It is. When I first started training, I would see some of these operations and I couldn't figure out how to start. I was like, how do they know this is here and this is here? And it was a learning process, but part of the training of surgery is repetition. And after seeing something thousands upon thousands and then doing something tens of thousands of times, you become very comfortable with it. And certainly there are always little things that may pop up and surprise you from time to time, but you learn as a surgeon to expect what's coming, to know when something doesn't look quite right, and you're on high alert for something abnormal or aberrant anatomy or some such thing. And it's certainly, I'm quite comfortable with it most of the time in the operating room. While we're diligent about our task, we can talk about other things and try to provide the best operation for that patient at that time that we can.
Right, and that's what you want in a surgeon, is someone that's comfortable, and you've done, like you said, you've done it so many times, and you probably have just a specific method that you follow, so it's always repeatable.
I do. I was extremely lucky when I first, I originally practiced in my hometown of Natchitoches when I first got out for about 4 years, and unfortunately just wasn't a good fit for me for many different reasons. And Dr. Banda, who is my partner now, had an opportunity here at Bossier. And it was a great opportunity. And Mike and I, Dr. Band and I, had trained together as residents at LSU.
Yeah.
And I joined, and within 2 weeks of joining, I hired a lady named Jackie Phelps. Hey, Jackie. And Jackie has been with me for the last 20 years. And it was one of the best hires I ever made. She assists me in the operating room, and she and I have a routine. We don't have to talk to each other. We don't have to ask what's next or anything like that. We have a very set routine how we do things, and she has made my life so much easier.
That's awesome. And I know my husband is a PA, first assist for a doctor, and it's really invaluable to have that that connection and that partnership, that you can rely on.
It is.
Yeah.
It's nice, and oftentimes in general surgery we find ourselves doing the same operations over and over, which I like. I think that sharpens you and makes you really good at what you're doing. Dr. Bannon and I each do about 300 gallbladders a year, and so that's a very common operation for us, and it's nice to have that system to rely on. There's some comfort there, and operations that I wouldn't commonly do, or I usually have a rule: if I feel like somebody can do something better than me, then that's where I send the patient. I think that's where they need to go. But for things like gallbladders and hernias, I feel like we do a good job with that sort of thing.
All right, and that's kind of the topic of what we'll be discussing today, is those common procedures that you see, and I'm sure it's hernias, gallbladders, you mentioned appendix or appendicitis. Anything else that you would say is common or not unusual to see on the operating table?
Sure, we do a lot of what we call lumps and bumps, which are small fatty tumors, lipomas, or cysts that oftentimes the dermatologist, and rightfully so, are not comfortable removing in their office. We'll take them to the operating room and remove those skin lesions. Also, we do colon cancer. Sometimes there are perforations of the colon, such as diverticulitis. We'll take care of that, remove that portion of the colon. Sometimes you can get what we call adhesions. The layperson would call that scar tissue in the abdomen from prior surgery that can obstruct the bowel, so we operate for bowel obstructions. We're kind of between the clavicles and above the pelvis. We're just all in.
All right, yeah, and like we said earlier, that a lot can happen in that area. So
Yes, ma'am. Yes, ma'am.
Okay, thanks, John, for joining us. First caller of the day. What is your question?
Okay, Dr. Howell, I was diagnosed. I had an ultrasound on me, checking for my gallbladder, and they told me that I had some cysts on my liver, 2 cysts, and 1 cyst on my spleen. And I was trying to see what kind of options do I have.
Yes, sir. Well, I would say that for the ultrasound of your gallbladder, I didn't hear if you had stones or not. Did you have gallstones?
No, I didn't. It wasn't my gallbladder. It was my stomach.
Okay. Well, to answer your question about the cyst, generally what we would call a simple cyst on the liver and or the spleen is really inconsequential. They don't require any surgical treatment or any drainage or anything like that. You can pretty much live out your days with that cyst and never have a bit of trouble out of it. Now, not having all the information in front of me, I don't want to give you any bad advice. The best thing to do is to have that ultrasound reviewed by your primary physician, or we actually are lucky enough to have hepatobiliary surgeons here in the community at Willis Knight North, and they do a great job at sorting that out. There are, of course, some very odd cysts, such as parasitic cysts and things like that. Certainly not a big issue in this country, but always a possibility. There are many, many things we have to worry about when we hear any kind of diagnosis. But I think that your primary physician certainly could steer you in the right direction with that. And if necessary, you're welcome to call my office at 746-4460, and we can easily get you to the right people to address that problem.
All right. I appreciate your help.
Yes, sir.
Yeah, thanks, John. And if you're just joining us and you have a question for Dr. Howell, that number is right there on your screen, and those phone lines are open, 318-219-4569. We are talking more about general surgery, anything that could possibly go wrong in the abdomen. So give us your call for any of those questions. Rick, thanks for joining us. And what is your question?
Well, I got one question is that I've been having, actually at Oxford LSU, and every time I go to do an ultrasound, they tell me I don't have a gallbladder. They ask me, have I ever had a gallbladder surgery? I told No, I never have a gallbladder surgery. So, and they keep telling me they can't find my gallbladder. So, I don't know if I was born without a gallbladder or what. Then I'm curious about that.
Yes, sir. Well, certainly, you can be born without a gallbladder. It's an incredibly abnormal condition, but it is certainly possible. In addition, ultrasonography, while a great test to look at the gallbladder and look for gallstones, is not 100% accurate. Most x-ray tests are not. There are other tests that can be done to assess if you truly have the absence of a gallbladder. There's a certain type of MRI that's very good imaging to look for that. But to briefly answer your question, yes, you can be born without a gallbladder. In fact, one of the first operations when I moved to Bossier was someone that they felt like they saw a gallbladder on the ultrasound that did not look good. And that patient, when I did the laparoscopy to remove it, had no gallbladder. And
Wow.
that was quite the introduction to Bossier. I'm sure all the personnel were like, who is this doctor who can't even find the gallbladder? But there was no gallbladder to be found. And many years later, I think 2 years ago, I had a young lady, same issue, was born without a gallbladder. It's incredibly uncommon.
Interesting.
Okay, yeah, I was wondering about that, but see, I got a procedure coming up again, and my doctor told me to tell them that every time they did the ultrasound, they can't find the gallbladder, and they were saying that maybe my gallbladder has been removed. And I told them, no, I ain't never had surgery to have a gallbladder removed. So
Yeah,
they asked me, when my next surgery come up, when it come up, I'm going to let them know about that. He told my primary doctor told him to let him know. So
yeah, well,
I got one coming up in December.
Yeah, I would think you certainly would remember if you had had your gallbladder out. And
Yeah, I remember that.
yes, sir. And the test is what they call an MRCP, which is a really good test to check out the biliary system.
Yeah, but I mean, yeah, he just said that. I mean, they did it twice, and each time they kept telling me, well, we can't find it. It's not showing up. They looked at the liver, they looked at the kidney, they looked at, well, see, it's not, your gallbladder is not showing up on it. So,
Well, I hope they get you get you straightened out there, sir.
Okay, well, I appreciate you.
Yes, sir.
Yeah, thanks, Rick, for joining us. And again, if you have a question for Dr. Howell, that number's on your screen, 318-219-4569. Ramona, thanks for joining us. Popular today, Dr. Howell. Thanks for joining us, and what's your question?
Thank you. My question is, I was diagnosed with pernicious anemia by way of pancytopenia and leukemia of the bone marrow, and because of my blood type in Houston, dealing with my situation was rare. I have since moved back to Louisiana, which is my home, just got into the system at LSU, and right now, because I'm older now, I'm seeing the manifestation of my diagnosis now. I just had a colonoscopy on yesterday, was treated for a polyp in the colon. Now I'm getting ready for the the test results to come back in for my gastrointestinals. My question is to you, doctor, is what I have been diagnosed with, they were able to find out I got it from my dad in birth. And I was also told that my intestines didn't fully develop because I was such a small baby at birth, or preemie. So where I am right now and the treatment that I'm receiving at LSU, or the symptoms that I'm seeing now, progression into the cancer? Am I progressing now into the cancer as opposed to when I was first diagnosed in 2018?
Well, and this is a lot of complicated and difficult information for sure. And as a surgeon, I'm probably not in a good position to speak about these entities. While I did learn about them many years ago as a young medical student, treatments are constantly changing. The treatment modalities we have new technologies all the time. I think that probably your best bet is to just continue to work your way through the system. I know it's a little frustrating when you move somewhere and you kind of seem like you're starting from scratch, but we're so lucky in this community to have good physicians. We have oncologists, hematologists, as you mentioned already, the good GI doctors, and they can begin to sort through these things. I think this is something that can't be easily answered with a phone call. I think we'll have to go through the entire process and rule out any and all other abnormalities that could be causing you trouble. I wish I had a better answer for you, but I think it would be foolish for me to try to diagnose such a complicated condition over the phone. And I think you're in a good spot, and just follow through with all your studies, and I think they'll get you to where you want to be.
Okay then, Doctor. I appreciate your time and attention in this matter. It seems just appear to me that I pretty much have to continue doing what I'm doing as each symptom arrives. I am with a good team, and we address the issue as they come along. So I thank you for your time and attention in this matter.
Yes, ma'am. I wish you luck with all this.
Thank you.
Yes, thank you, Ramona. And kind of switching gears back to, gallbladder hernias and appendicitis. Appendicitis is one of those things that we were talking off air about it. Could you tell us a little bit about like those symptoms? To me, and maybe others, I always think of, it's going to be this really excruciating pain, and you will know that you have appendicitis, but it might be a little bit more ambiguous than that.
It can be. There's certainly some cases, some indolent appendicitis. Most commonly, you're going to have what they call the march of symptoms. You're going to start off with a little abdominal pain around the belly button that's sort of mild and crampy, and then eventually over the next 24 hours or so, that pain will migrate down into the right lower part of your abdomen. And that's a classic tell for appendicitis. Whenever the emergency room doctor hears that, they're on high alert for appendicitis, and rightfully so. Occasionally, there will be some patients who the appendix may be located in abnormal condition, and they may just have some vague cramping over a week or so, and the appendix is just getting worse and worse over that whole time. And sometimes those patients can present in extremis with a ruptured appendix or a perforated, what we would call a perforated appendix, and can be in a bad way. So it's a little different for everybody, but the most common presenting symptom is going to be pain that starts around the belly button and then radiates down to the right lower quadrant. And it's pretty much a persistent pain once it gets in the right lower quadrant. You know, everybody has some belly aches from time to time, but as you mentioned earlier, I think if you have appendicitis, you're pretty much going to know it, unless you're one of those more rare situations where the appendix is abnormally located, or you have a condition where you're unable to tell that you have appendicitis. You know, certainly there are some older nursing home patients, sadly, that suffer from dementia, who cannot explain or express that they're feeling poorly and what's going on. Occasionally those patients will have a late presentation with a really bad appendix. Some patients also, unfortunately, perhaps have some sort of paraplegia or sensory deprivation where they're not feeling abdominal pain the way you and I would feel it, and they too can present with a very late, complicated appendicitis.
Interesting. And the appendix, what purpose does it serve in the body?
Well, right now, in 2025, its purpose is to cause trouble. I think when our ancestors, many eons ago, when we were scavengers and just eating whatever we could get to eat, it served a function to help. It's got a lot of lymphatic tissue, and it helped to filter some of the toxins that may be in the foodstuffs and scavenged material that they were eating. So it helped to purify those things so they didn't get sick from eating this sort of stuff. But hopefully we don't need that function anymore.
Right, yeah.
And it's just a remnant from that time.
Interesting. Yeah, it's always one of those weird, body parts that we have that it's like you said, just causes a lot of trouble. And
it does.
So when it does cause the trouble, appendicitis, obviously inflammation, but where does that inflammation, is it known where it starts from, or is it seemingly random?
We do know that the appendicitis is caused, the appendix attaches to the first part of the large intestine, the colon, large intestine, colon, same thing. It attaches to the first part of that, and it drains into the colon. When the opening to the appendix gets clogged up, what we call the appendiceal orifice, when it gets clogged up, the appendix will begin to swell because it can't drain anymore. And the fluid that it swells with is like a buffet for bacteria. They love that fluid, and they will get in there and replicate and cause inflammation and swelling of the appendix, and that's where the problems begin.
Yeah, and you want to get it taken care of because, like you said, it could still be fatal even in 2025 if you're not getting it taken care of.
Absolutely.
Okay. Okay. And then other things like gallbladder, and you do elective and non-elective or emergency surgeries. And of course, someone would probably rather see you in an elective situation,
Yes.
but with the gallbladder, that could be both elective or it could be, end up being an emergency situation. So can you tell us those symptoms associated with that?
Sure. Usually the classical symptoms for biliary disease, gallbladder disease, you're going to eat something, usually a fatty food, which is almost impossible to avoid in Louisiana. And within about 30 minutes or so of eating, you'll develop some upper abdominal pain, often associated with nausea. The pain is usually underneath the ribs, although many times it could be right in the center of the upper abdomen and occasionally radiating to the back. Those are the most common symptoms. And it's usually recurrent. You'll have an attack in April, and then you'll eat and drink and be fine. And then all of a sudden in June, you eat something, you feel the same symptoms again. And that's one of the things that I always warn my patients about. If you're having recurrent pain that's the same, there's probably something going on there that we need to sort out. And that's the most common symptoms. Now, some poor patients, the first gallbladder attack they ever get is terrible and severe, and they're in the emergency room, and they have a bad gallbladder that's gotten so distended and inflamed it can have some gangrenous changes on it, and those gallbladders need to come out.
And the good thing is you can live without the gallbladder. You might have to maybe make some dietary changes after.
Right.
But for the most part, people have great success without a gallbladder.
They
right?
do just fine. I myself don't have a gallbladder,
Okay.
and can certainly speak to that from firsthand experience. Most people will have some dietary issues for the first 6 to 8 weeks, but after that, your body begins to adjust. And as I mentioned before, doing about 300 of these a year, if everybody just had terrible dietary issues, there'd be people beating down my door to beat me up. There would be so many people mad at me. But it's a really good operation. We do it laparoscopically now with 4 tiny incisions, and the surgery maybe takes 20, 30 minutes for a routine one. And then you get to go home. It's a day surgery. You just get it done and go home. You don't have to spend the night, which is, as you mentioned, why I stress, let's get this done before it gets too bad. If you come in with a terrible gallbladder and we can't proceed safely with the laparoscope, we have to make a large incision in the belly, get our hands in there and do it the old-fashioned way. Then you're looking at a week in the hospital, 6 weeks of recovery, and we would all look back and say, why didn't we just do this before it got so bad?
Right, right. Yeah, so definitely listen to your body if you have any of those symptoms you mentioned.
Yes, ma'am.
Get it checked out. Because you might be able to debunk this. I've heard when you lose weight really quickly, that could put stress on the gallbladder, maybe cause gallstones. Is that correct, or have you seen that?
I have seen that.
Okay.
I don't think it would cause the gallstones. There's a whole different mechanism for that.
Okay.
But the rapid weight loss, for some reason, if there's a reason for it, I'm not aware of it, but for some reason the rapid weight loss can cause some dysfunction of the gallbladder. It used to be routine when they did the gastric bypass for weight loss before laparoscopy. They did the big open procedure and would bypass the stomach for weight loss. They would take the gallbladder out at the same time always, because they knew as they begin to lose weight they were going to start having gallbladder issues. And I have seen many, many patients who have lost weight and developed gallbladder issues. They may have always had the stones there, but it didn't give them trouble until they lost that weight. So for me personally in my practice, I do feel there's a definite correlation between weight loss and biliary trouble.
Okay, and probably specifically that quick, rapid weight loss as well, especially if you have bariatric surgery, it's going to be really rapid. Do you think it maybe depends on the time in which you lose that weight too, maybe?
I've seen it both ways. I've
Yeah.
seen people who have lost weight from the old-fashioned way of just eating better and exercise,
Yeah,
and they
okay.
still end up with some biliary problems. But I do think that there's a higher percentage of those with rapid weight loss that have issues than those that do it slowly over time.
Very interesting. And it's just, you've seen, like you said, you've seen the correlation. Do we kind of maybe have a reason why, other than you're losing fat quickly and maybe.
I am not sure. There very well may be a reason out there. Somebody smarter than me could probably answer that, but I'm unsure the exact physiology of that.
Yeah, very interesting though. Okay, so we have just a couple minutes left. Hernias, kind of course, we can't tackle this whole big conversation in 5 minutes, but just a synopsis of hernias. Tell us a little bit about what it is, and you can have them in many different places in your body. You
can. Mostly, I'm dealing with abdominal wall and inguinal or groin hernias. And there are several different types of hernias, but all hernias have one thing in common. They're a defect in the abdominal wall, that is the muscle and the gristle that basically keep all your guts in place. There's a hole there that is allowing things that should be on the inside to bulge through that hole and be on the outside. So unfortunately, there's no magic pill or exercise to make that disappear. You have to have surgery to fix these, and they will only get bigger over time. They will not go away. And the way we fix those is we make an incision over the hernia. We find the hole. Anything that happens to be bulging out of that hole, we're going to tuck it back in where it belongs inside the abdominal cavity. And then we take a piece of mesh, some synthetic material, and basically patch that hole just like you would patch a hole in your tire. Okay. And when we put that mesh over that hole to keep that hernia from recurring, the mesh takes the place of the belly wall that you have lost.
Interesting. What are those symptoms associated if somebody's curious, like maybe, do I have a hernia? Will you know for sure?
Most people are going to know because there will be a bulge there.
Okay.
They oftentimes they're not even painful. They'll say, hey, doc, I got this big lump right here. It's not hurting me, but I don't know what it is. I noticed it when I was showering, which is very common for men because men get inguinal hernias very commonly as opposed to women. And most of the time that's what they'll tell me, and sure enough, they have a hernia there.
Wow. Okay. And with hernia surgery, and that's elective, right? You can get that done electively, or in some situations, would it lead to an emergency?
It can lead to emergency, which is almost like the gallbladder talk. It's something we want to take care of before we get to that point. Every so often, I'll have somebody come in about 1 in the morning. They'll have a hernia that's not been taken care of, and a piece of bowel can get out there and get stuck. And not only get stuck, but begin to swell and actually pinch off its own blood supply. Then you have dead intestine inside of the hernia. And certainly you don't have to be a surgeon to know if you have dead intestine, you're not in a good place. And so then we have to, it changes from a simple hernia operation, which is going to take about 20 or 30 minutes, to something where we have to open the belly, we have to remove part of the bowel. It's much more complicated and much rougher recovery.
Okay. And with prevention of hernias, is there any way to prevent it, or are some people more prone to developing hernias?
There are some people who seem to be more prone to developing hernias. They think that these patients, there's unfortunately no way to screen for this that I'm aware of, but they have a defect in their collagen. Collagen's sort of like the glue that holds everything, all the soft tissues together in your body. And they think because of that lack of integrity of that glue that they're more prone to develop holes in their abdominal wall. Also, a very common cause of hernias is if you've had a prior operation. If someone has been in your belly, certainly we do the best we can to close everything up like it was before, but you're at a risk for developing what we call an incisional hernia because it's a hernia related to a prior incision.
Makes sense. Okay, yes, well, and definitely want to make sure, I think at the end of the day, you're an advocate for yourself with your doctor, if you notice anything weird or if you feel anything off, then definitely want to get that checked out before it becomes, like you keep saying, urgent or emergent.
Yes, yes.
Okay, so maybe the best course of action would be to reach out to, if somebody was having any of these issues, reach out to their primary care. Then would they then refer to you, or can they reach out to you directly?
They can reach out to us directly. Oftentimes we get the patients from our primary care doctors. We're so blessed at Bossier to have such a great network of doctors ranging all specialties, and our primary care support is fantastic, and they're really good at finding surgical issues and getting them to us. And we're very grateful for that, and I'm sure the community is grateful for that as well.
Okay, and so you are located at Willis Knight and Bossier with Surgical Associates. Where is that, and what's the best way that somebody can get in touch with you?
The best way to get in touch is to just call our office directly at 746-4460, and we are located just north of 220 in the Willis Knight and Bossier complex, Suite 250.
All right, easy enough. Thanks, Dr. Howell, for joining us, and thank you for joining us as well. This will also be on our website. If you wanted to rewatch it, or if you missed part of this conversation, ktbs.com/podcast, also on Spotify.